My responsibilities are to manage a $564 million program that we parceled out money to each of the states and 5 territories in the District of Columbia to develop exchange within those areas, and if they follow national standards, which we're encouraging them to do, we'll have a nationwide exchange. We're trying to provide the capability for each provider to have at least one option for exchange to meet the meaningful use requirements, the EHR incident program from CMS. Well, the biggest difference about California is just the vast size and complexity of the environment. California has, just such a huge number of providers, a huge number of labs and pharmacies, and where a lot of states are able to go and track each provider to know where they are, each pharmacy or each lab. That number is just too big for California. So really, California has to look at their state at the macro level, and then work with partners to go and reach down to make sure that every provider is served, every pharmacy is served, or every laboratory is served. So it's really a matter of scale. So what's unique about California Health Information Exchange is really kind of 2 different groups of exchange, types of exchange. One is a community-based exchange in which a group of stakeholders get together, they establish a governance, and they determine the rules for exchanging, they determine the infrastructure, they get together and help fund the infrastructure for exchange. And then the other type of exchange is called the enterprise exchange, and that's really more of a organization or a small group of organizations that are somehow affiliated with each other, and they determine, really based on organizational needs, to exchange data. Now, both of them are very important, and there's no right or wrong way to exchange. What we're hoping to do, though, is encourage exchange across those organizational boundaries and, of course, across those community boundaries. Priorities for the State Health Information Exchange Cooperative Agreement Program this year is really, number 1, HIE adoption. We have to show that people are really using the exchange that we've helped establish in each of the states. Demonstrating also that there's some real value in the exchange. And so it's really about HIE adoption, showing the value. And then in addition to that, we are really encouraging states to focus on stage 2 meaningful use, and including things like public health within their offerings, things like consumer access, and those are really the things that we are encouraging states to do because they add so much value, and they help out the providers in so many different ways to improve the quality of care. There's several things. For one thing, just this past quarter, we were able to reach the milestone of 80 million directed exchange messages that were sent. In addition to that, 3 million queries for patients, looking at patient information. So we're starting to see the volume come up. In addition to that, we have about 11 million providers that are enabled for directed exchange. And so, we have a long ways to go, there's no question about it, but we are actually starting to see the numbers starting to increase now for both those who are participating, but as well as the numbers of transactions. Some of our biggest challenges are what I was just talking about, was encouragement. It's really getting people to use the information. Providers, when they participate, it's like peeling an onion. So, first we have to encourage them to get educated, why Health Information Exchange. Oftentimes they have to sign some kind of a user agreement, and then next they have to go and connect to the exchange, and then they have to start using it. So every step there's some challenges to get them to participate, and we have to find better ways in which to speed up that process of getting providers to participate. So some states are able to establish a single statewide HIE. They're usually the smaller states. They're usually states that have been at this for a long time. But the reality is, in most states, there's a variety of exchange that's already taking place. And so while there may be a state-funded health information exchange, but there's also EHRs who are enabling exchange across the people who use the same kind of EHR. There's oftentimes a public health or some other group of people who decided to exchange information at the same time using a different infrastructure. Of course, there's IDNs, hospital systems, and others who are also exchanging data. And so it's actually very rare to see just a single HIE that meets all the needs of all the different providers within a state.